So just to start the panel discussion, I was going to ask each of the members, starting with Stanley, to comment on this sort of general question. And it's, the theme is cost of vaccines and available to all human beings who would benefit.
That's easy.
With, and, a couple of times Stanley used the word altruism, but he also highlighted other issues, including greed. And so, Stanley, the specific question on this theme, as scientists and clinicians and experts, do we have a role to generate guidelines or policy or, a universal approach to how we balance cost, availability, altruism, and reduce greed as much as possible? Stanley, you're first, and then Anthony.
So I think that there's two different answers to both parts of that question. The greed issue, I'll start with first, because I think that is mostly one that, particularly in an era of social media and widespread questioning, that we just have to be accessible to answer questions and address them as straightforwardly as we can. And the greed is not going to go away, but so much of it is based on misinformation and people wanting, having some skepticism of healthcare providers and health authorities. So I just think it's, for that part, we have to be as accurate as we can. And as I mentioned in my talk, be as nuanced as we can, because we can't pretend to know answers when we don't really know answers, particularly as we learned in the pandemic when answers change very quickly. In terms of the other part, I like to think of, in terms of vaccine development and the more positive parts of the response, I think that our role is not only to help prepare products, but to advise policy. Unless we're specifically on a policy creating committee, I think it's best to let the policy be made by people with a single voice, and we provide input to them. That's not to say we should be silent, but I think it's important to recognize, or at least I think my role and what I've done is more as an advisor than as actually formulating policy, except when requested. I'm on one of the panels for the FDA for vaccine recommendations, and it was clear there that we didn't establish policy, we made recommendations that were then followed.
Thank you. Anthony, any comments? And in particular, is cost effectiveness the gold standard?
I mean, I guess cost effectiveness is, important in the sense that, you have a limited resources and limited budgets, and you want to sort of spend your money in a way to achieve the most good in society. It's really, people sort of think about it sometimes as, penny pinching, but ultimately you want to sort of, I think about it more as an ethical endeavor, in the sense that if you're spending your money inefficiently, then you're not doing as much good. I guess the complication is that, unlike some interventions where the prices are fixed, here the prices for vaccines, negotiated with companies, so it adds a layer of complexity. I guess in terms of the more general question, I think particularly for lower middle income countries, I think there's, we obviously in high income countries perhaps, can afford to pay greater amounts for new vaccines, but for lower middle income countries, it's really important that they're provided at an affordable price, and that they're provided in a timely way. Sometimes there can be delays, from when things are available, or in terms of being funded in high income countries to when they're rolled out in low income countries. And I think that's something that we should be trying to have them roll out faster in those settings, which sometimes have higher rates of disease.
Tony, any comments?
I think the other speaker spoke very eloquently.
And Sanjay?
Yeah, I mean, yeah, I agree. Yeah, I mean, with the comments that have already been made, but looking at PCV, I mean, trying to expand on what Anthony said, making those vaccines available for children in low and middle income countries. I mean, it's more than 20 years since we developed the first, highly efficacious PCV. And there are, many parts of the world where the disease incidence for, severe pneumococcal disease is much higher than places where this vaccine is available. It's been available for many years. Its cost is the main factor that's preventing them accessing. So we are, discussing about, what the best schedule is, and there are places in the world where they can't even afford a single dose of the vaccine. So I think there needs to be, look at this from that perspective.
Just before that, Rod, there was an online question from Raina McIntyre specifically about Australia's approach to pneumococcal vaccination in older Australians, which it is different from most other countries. Our age cutoff, I think, is higher. And Raina's comment related to the risk of pneumococcal disease after someone's had influenza or COVID, and the wisdom of us restricting or apparently restricting pneumococcal vaccination in older people. Tony, that question is to you.
Yeah, I mean, I think I did mention that in a previous edition of this meeting, I went through the history of approval of conjugate vaccine in adults, and it was really a long saga, and cost played a major role in that. And I think the 70-year cutoff is a more pragmatic cutoff for balancing both benefit in the highest risk people and the costs, because each, I don't know the figures, but I imagine that giving it to everyone age 65 versus giving it to everyone age 70 had a significant cost. And the way it was worked out, the benefit wasn't as great. So, I mean, sure, it would be great to increase that. I think, though, really importantly, and I did mention that, was that people with risk factors who are less than 70, down to 12 months of age, are also the people at the highest risk are eligible to receive the vaccine as well. And that took an enormous amount of work for a lot of people to get that, to even just get that through. So I think I'm looking more optimistically rather than saying that we do have some way to go. So,
All right.
My question's about the cost effectiveness of a failed delivery. So fantastic vaccine, but it doesn't. So my question is about how you build that into your modelling. And Australia spent $18 per successful vaccine in 1996. At $33 million a year, we went from a 55% vaccination rate to 90% vaccination rate in our children. So how do you factor in the cost effectiveness? Because we suddenly have 90% of our population receiving our vaccines. We've invested in the infrastructure. How do you model that in with a new vaccine or a program when maybe we only get 35% flu uptake or something like that? So what are people doing to sort of invest in that modelling that is dynamic and related to infrastructure?
So, Anthony, maybe you could start, and the word communication probably needs to be included at some stage by someone.
Yeah, I might leave the communications to others, but I think I can just talk at a very general level. I guess, typically, at a general level, economic evaluations, the published ones, they don't really look at the I guess the dynamic, as you said, the sort of dynamic nature of program delivery. You look at, usually you'll find that they assume an administration cost, but it is true, as you say, that if you're building infrastructure, then perhaps the administration cost can change. And if you build infrastructure for one vaccine, then that can subsequently be used by, or potentially be used by, new vaccines that you're introducing. So it is more complicated, as you say, than we sometimes assume in these models. Typically, what is assumed in the sort of published literature around this stuff is that you assume a vaccine administration cost, and it's sort of fixed per person, and you can vary that, but that's typically the way that it's done. But I agree, it is more complicated, particularly maybe in Australia. I guess we have sort of fairly set up systems, but particularly in lower middle income countries where they're where vaccine delivery can be more complicated and still. But yeah, it's a good point. It is sometimes a bit more complicated than the way it's done in models. And I think we have to sort of make some simplifying assumptions sometimes because we don't have data, and these things would be very complicated to model. And if you don't have the data to do it in a way that can produce realistic predictions, then sometimes you do simplify the assumptions in the model.
Anthony, thanks. Tony?
I mean, just really important. I think we've continued doing very well with childhood immunisation. And I think adult immunisation, which is the theme of this whole organisation, I think has been more of a challenge. I did want to say one thing, though. There was one of the talks last night where someone mentioned the disappointing uptake of COVID-19 vaccine, and I really disagree with that. There's an extraordinary uptake, actually, in most of the adult population. Sure, we had a small vocal opposition, but to me, that actually assisted in the promotion of adult vaccination. And I think in our older population also, some of our uptake is maybe the whole population influenza uptake Ian wasn't happy about, but the uptake in the higher risk older individuals is reasonable. If not, hopefully we can do a little bit better. But I think people still are very pro-vaccination in children, and even maternal immunisation. My understanding is if you tell the mother that that's for the child, they have a much higher uptake than if it's for themselves. So people, I think, still are. I think we still have a way to go in educating people about adult vaccination.
Thank you. John?
Thanks. Tony and Sanjay, could you talk about pneumonia? Pneumonia is the elephant in the room, and it's 10 times the number of cases compared to IPD. As a clinician, people are going to have no idea what IPD is when they come to see it, but they have an idea about pneumonia. I understand from both the vaccine manufacturers that they have methods of assessing their own serotypes, but they're not necessarily made commercially available, and we are not monitoring the other serotypes with community-acquired pneumonia. So can you have it? Why isn't that on the radar at all in terms of talking about it when we know that it's 10 times the number of cases? I know it's difficult to measure. We measure IPD because it's there and it's got a sample that's reliable and consistent. So why aren't we working on better assessment measures to actually determine the impact on pneumonia?
So I'll start, Tony. Yep. So very good point. Yep. So non-bacteremic pneumonia is, we are saying 10 times higher. Some estimate that to be about 30, 40 times higher than invasive pneumococcal disease. We don't have a good way of getting a good handle on what that burden is here. So yes, serotype specific urine antigen tests are available that detect those vaccine serotypes developed by those companies. But there is also a serotype specific urine antigen test developed by the Public Health England, now called HSA, which also detects 24 of the serotypes. There is Binax Now test, which is not that sensitive, that can also diagnose a non-bacteremic CAP. Yeah, so totally agree there should be a better mechanism. And I might also, go on to say that so one of the projects that I'm currently, working on is a pilot study just in a single center where we would try and estimate this non-bacteremic cap burden using the tests that's available from the UK. So yeah, maybe in a couple of years' time, if I'm invited to a conference by Immunization Coalition, I can show you some of that data. So it's that work we are planning to do, yeah, but it's area of knowledge gap, definitely.
Sanjay, thanks. Tony?
Yeah, I mean, it's a really important point, but I mean, we're pretty bad at diagnosing even the condition of pneumonia or confirming it. I'm interested in Lou's comments on this from an adult respiratory physician. But in terms of determining a cause of pneumonia, it's really in the small minority of cases we do that. The urinary antigens for pneumococcal disease have some issues in diagnosis as well. But you're right, and I think I did mention that there are studies now looking at all-cause pneumonia, which do demonstrate it was up to about a 10% reduction in all-cause pneumonia, although these studies have some methodological issues. So it does seem to have an effect, but it is really important.
Because we don't have, and we know that pneumococcal as a cause of community-acquired pneumonia is halved in the last 20 years or so, and whether that's an effect of the vaccines, we don't know. But in terms of what Tony Newell was saying with the economic evaluation, pneumonia does have a cost. Not everybody ends up in hospital, but a lot of people need intensive medical care, and they're often after consequences. So if we can better attribute that and work out how much of that is preventable by the disease and how much is due to the non-vaccine factors, then that will make the modelling more precise as well.
Thank you. Stanley, the concept of one infection then predisposing to a second, and for example, influenza and COVID, then making people at more risk of getting pneumococcal bacterial pneumonia. Are there other possibilities in the sort of the microbes that you were considering as possible emerging pathogens?
You mean other microbes that could do the same kind of sensitization to a second infection?
Yeah, by reducing innate immunity, for example, or other specific immune responses.
Yeah, so I think the data on I don't know all the data well on this. I know there are studies that show there's increased sensitization after a flu infection to bacterial infection. I think we know about that from history as well as recent work. I think that sometimes I don't know the data on having one viral infection followed by a second one. I think there's some controversy there because depending on how long after the initial infection the second one occurs may impact whether whether there's actually some protection or worse disease. But I would think in general one can say that any viral infection will enhance the likelihood of developing a bacterial pneumonia. There's certainly no evidence I know of that that there's any protection against bacterial disease, though there probably are in some preclinical studies. So in general, I think there's I can't give you a really specific list of pathogens, but I think in general pathogens do create opportunities for second pathogens, and we also know from clinical experience that co-infections are often worse than infection with a single virus. But other than that, I really don't have good data to address that question.
Thank you. I was asking in the context of whether that should affect our economic analysis of preventative vaccines, and particularly pneumococcal vaccine, for example. So a previously well 60-year-old might become more prone because they've then been part of a pandemic. Would anyone like to comment on that? Anthony, I guess there's no specific data.
No, I don't really have a comment on that. Yeah, sorry. I guess if there was data, just in general sense, if there's data that there's the interaction between infections and it's seen as being potentially important, then you could model it. I think probably what would be difficult is the lack of data. There's Sometimes we know that something can have an effect, but to actually sort of parameterize it in a model, you have to have a specific, amount that it increases the risk or decreases the risk, and having that specific value with any certainty gets complicated. So if there was good data on it, then it certainly could be modeled, but I'm not across it at the moment.
Thank you. Tony?
I mean, I suppose the comment I'd make is it sort of works both ways. So it would be beneficial to be immunised against influenza and against SARS-CoV-2 to hopefully reduce the risk of pneumonia.
Yeah.
But also, from the previous question, if you do get one of those viral infections, it'd be pretty useful to be vaccinated against pneumococcus, which is a complication of those viral infections.
Absolutely. Yeah. And I think that's probably a good spot to stop. But Stanley, just while we've got you online, you mentioned the word messaging. I'm sure you've been giving messages for many years. Do you have a lesson learnt or a tip for a young player regarding scientific messaging?
Well, the two things I learned from early in the pandemic is, first was to know as much as I can as of the day that I was being asked the question. And I put it like that because during the pandemic, we had so much data were coming in early every day. So as much as one can to stay up to date. And as I mentioned in my talk, I just think it's so critical that we be as accurate as possible, that we speak a language that people who are asking us can understand. We talk to them not in a very level way, not patronizing, nothing that would put them off listening to us, and then be as accurate as we can, and recognize that, especially in a pandemic, things are changing so quickly. In other settings, I think being knowledgeable and conveying accurate information with as much as possible is the key thing. Accuracy and gentleness is what I would say in presenting information.
Stanley, thank you. I think that's a lesson for all of us for life. I'd like to thank you, Anthony, Tony and Sanjay, for fabulous presentations.